Study about lung transplantation, part 2 of Bailey, chapter number 92. Okay, so the first human lung transplant performed by James Hardy. So remember heart and lung, all 4 letter. Okay, okay. Now 80% of lung transplantation are bilateral. MCQ. Okay, so long-term outcome of all recipient pathology are superior with bilateral lung transplantation. So lung transplantation is most common and it's superior. Okay, so single lung transplantation cannot be used in disease where infection may remain in other lobes such as cystic fibrosis and bronchiectasis. Okay, remember cystic fibrosis two name दोनों lung. So you need two lobes. Okay, bronchiectasis B, so two lobes. Okay, okay, okay. So most common indication of lung transplantation is COPD, cystic fibrosis, pulmonary artery hypertension, and interstitial lung disease (ILD). Okay, so there is a lung allocation score. Okay, so in which you need to take 17 patient related variables. Okay, so this 17 is an MCQ. Okay, so pulmonary disease and type of transplantation. So this table is important. So in cystic fibrosis, already told two name, so two bilateral. Okay, and you need a living related. Okay, living. So they will ask in which disease you need a bilateral lung transplantation and living donor. So it is cystic fibrosis. Okay. Next is interstitial lung disease ILD, fibrotic. So in which case you can go for bilateral or single. Emphysema or COPD, you can go with that bilateral or single. But in emphysema, you need a bigger lung, and in ILD, you need a smaller lung. Okay, then small size lung. Okay, then the pulmonary hypertension, you need a bilateral, or better you go for combined heart and lung transplantation. Already told you PAH. So P is pulmonary, H for heart. So in PH you need both lungs and heart transplantation. Okay, now come to the in idiopathic pulmonary fibrosis, you can do first you go for antifibrotic drug. So in MCQ they will ask what are the antifibrotic drug. So there are two drugs, nintedanib and perfenidone. Perfenidone. Okay, so this is MCQ. Okay, okay. Next, the contraindication of transplantation. So comorbid condition, okay, that is unusual to transplant patient over age of 17. So over age of 70, it is unusual to transplant. Okay, and there is comorbidities. Okay, so previous surgery such as lobectomy, lung volume reduction, pleurodosis is not a contraindication to lung transplantation. So important. So previous surgery is not a contraindication. Okay. So there is a untreatable major organ dysfunction like severe atherosclerosis, bleeding diastasis, high and low BMI. Remember, even the low BMI is also contraindication. Okay, severe osteoporosis and chronic infections all are contraindication. Okay, some infection like Burkholderia, Synopexia, and Burkholderia gladioли and Mycobacterium abscess. Okay, so these are associated with poor transplant outcome. So remember at least Burkholderia and Mycobacterium abscess. Okay, okay. Next is donor lungs falls. Oxygenation of donor lung fall below standard criteria of 300 mmHg. Aggressive donor management with alveolar requirement, ventilatory optimization, and bronchoscopy diuresis can lead to improvement. So remember this oxygenation of donor lung fall below standard criteria of 300 mm of Hg. Okay, so there is a standard criteria of lung donor. Okay, so in regarding investigation and history, first we will take history. Age should be less than 55 years. Smoking so less than 20 pack year. So remember, no smoking is not a criteria. Smoking less than 20 pack year. Okay, and there is a no chest trauma aspiration and pneumonia. Okay. Regarding investigation, there should be a clear chest radiograph, negative gram stent for bronchial secretion or pleural secretion, atrial oxygenation tension more than 300 mmHg, that is inspired oxygen fraction of 100% and positive in expiratory pressure 5 mm of Hg. Okay. So lung from older donor like more than 55 years can be safely used to 70 years of old. Okay. Means if there is older recipient, so you can go for older donor also. Okay. Okay. So regarding the management, how you are going to prepare the case, so heparin is administered and main pulmonary artery cannulated, prostaglandin is also used, and induce pulmonary vasodilation, that is prostaglandin, and 3 liter of cold cardioplegia is also used. Okay. And lung ventilation continues during flushing. Okay. Okay. So you tell me in which organ donation no need of flushing. Okay. Write in the comment. Okay. Lungs are more resistant to warm and cold ischemia time. Okay. So it is 6 to 12 hours. Okay. So it is resistant to warm and cold ischemia. Remember, important MCQ. Okay. So the first you have to do bronchoscopy and then lungs is inflated. Okay. So this is ex vivo lung perfusion, ex vivo, outside the body, donor body. Okay. Okay. So most donor involve control withdrawal of treatment, matrix 3 or uncontrolled DCD 2. Okay. So mostly matrix 3. Okay. So ex vivo lung perfusion EVLP is recommended to allow all the assessment. The picture you have seen just now. So ex vivo lung perfusion. Lungs are ventilated and perfused with electrolyte protein solution for 2 to 4 hours. Okay. Okay. So this will reduce the ischemia time, and this is also reduce the pulmonary edema. Okay. And you should do bronchoscopy can be performed to resolve areas atelectasis. Okay. So this is the system picture diagram. So typical ex vivo lung perfusion of the circuit. So in use there is a ventilator, leukocyte filter, hemoconcentration, reservoir, pump, everything. So they will not ask the question. You can just see temperature probe placed in upper left atrium. Just remember that. Okay, left atrium. You put the temperature probe. Okay. Okay. In this picture, they will ask what kind of incision it is. Clamshell. Okay, clamshell in thoracotomy. Okay. Okay. So operative technique, you give clamshell thoracotomy incision and at the level of 4th and 5th intercostal space. Okay. Okay. There is also called Stinsky clamp. Okay. That place along the left atrium, and during this surgery transplant you need to excise the mediastinal lymph node. Okay. Okay. Then anastomosis between the bronchus, then left atrium, and then pulmonary artery. So order of transplant will be bronchus, left atrium, and then pulmonary artery from the behind to front. Okay. Okay. So this is showing the anastomosis. Okay. Now come to the outcome and complication. Median survival after pulmonary transplant is 6.2 years, and median survival after heart transplant was 12 years. Okay, remember that. So main cause of post-operative mortality is primary graft dysfunction. Okay. Okay. So main cause is primary graft same as a heart also. Okay. And there is bronchiolitis obliterans syndrome associated with graft dysfunction. Okay. So complication of lung transplant are primary graft dysfunction, bleeding, parenchymal and pleural infection, bronchial anastomosis, dehiscence or stenosis, vascular anastomosis, stenosis or kinking. Okay. Rejection, acute and chronic lung allograft dysfunction, CLAD. So this is also an MCQ, CLAD. Okay. Then infection can be due to bacterial, viral and fungal, and phrenic nerve palsy, important. Okay. And gastroesophageal reflux disease. Okay. So immunosuppressant after heart and lung transplant, two types. First is induction therapy, then is maintenance. In induction therapy, you can give anti-thymocyte globulin or interleukin 2 receptor antagonist, okay, basiliximab, okay, important MCQ. And then maintenance is triple therapy like cyclosporin, azathioprine, and methylprednisolone, okay. Okay. So infection is second leading cause of mortality within 30 days. So first was primary graft dysfunction. Okay. So lungs from hepatitis B core positive donor is feasible with low risk of transmission. So even the hepatitis B core positive, you can go for transplantation. Okay. So acute cellular rejection. Okay. So it will around 30% seen in 30% patient, and there is acute decline in pulmonary graft function. Okay. So what is the treatment? Pulse high dose of steroid. MCQ. What is the treatment of acute cellular rejection? Steroid. Okay, in pulse high dose of steroid. Okay, and with modified or augmented immunosuppression. Okay, in resistant case. Antibody mediated rejection is donor associated antibody directed towards donor HLA. Okay, so neutrophil migration, what you are going to see on histology, neutrophil migration, arthritis, evidence of complement activation, that is C4D. Okay, so in which case it's antibody mediated, so you have to go for plasmapheresis, okay, to deplete circulating DSA. Okay, then intravenous immunoglobulin and rituximab. Okay, now it's clad. Okay, clad, which include BOS. Okay, so extracorporeal photopheresis is combined with augmented immunosuppressive regimen. Okay, and total lymphoid irradiation and perfluridone. Okay, antifibrotic agent. Okay. Okay, so gastroesophageal reflux disease is very common after pulmonary transplant. Okay, and had strong association with clad. Okay. Okay. Then bronchial anastomosis is common site of complication with dehiscence. Okay. Okay. So these are the picture you can get in the image based question. So you can see this is the single lung transplant, double lung transplant, lung with heart transplant, lobe transplant. Okay. Okay. So the last topic is heart and lung transplant. So already told indication. They will ask mainly indication. So PAH, pulmonary and heart. Okay. So main indication, congenital heart disease with pulmonary hypertension or early post-transplant survivor remains lower than after lung transplant. So Eisenmenger syndrome. Okay. You remember Eisenmenger syndrome is indication for heart and lung transplantation. Okay. Okay. Now future artificial lung mimicking the source of success of VAD, ventricular assisted device. Okay. Okay. And cardiac transplant remains a gold standard for treatment of end stage heart failure. Okay. Remember this line. Okay. Thank you. The last 1 minute important MCQ from this. So heart perform the first. Okay. Mostly bilateral, and this is superior. Okay, now come to the indication of bilateral and unilateral. Okay, then they will ask you the donor criteria. Okay, this. Okay, then this line, the lung is more resistant to warm and cold ischemia. Okay, and then mostly matrix donor 3. Then okay, and this incision is clamshell thoracotomy. Okay, then they will ask the complication of lung transplantation. Okay, and then type of immunosuppression. Okay, and what is the treatment of acute cellular rejection. Okay, and this image is important, and heart lung transplant indication. Okay. Okay, this much you should know about this chapter. Okay, so with this we finish the chapter number 92 of Billy and Love 28th edition.